Idea. All right. Well, I am Dr. F. Sott Feil. I am a physical therapist, 16 years now. Recently transitioned into academia about 3 or 4 years ago. Mostly focusing in geriatrics. I teach the geriatric course for University of St. Augustine on the Austin campus for their Flex program. Patient care 1 and 2, which is like transfers, gait training, assisted devices, tubes and lines, that kind of stuff. And then intro to physical therapy. And I was teaching the documentation course and the intake course, but I think I have moved those on to somebody else so that I can teach the business and admin course, which is another passion of mine. So a lot of teaching, a lot of educating. Not as much treating these days, but still very passionate about geriatrics, trying to help out with the geriatric section. Definitely working on my GCS. I'll be taking that sometime next year, so don't know why, but it is what it is. Yeah, I'm just happy to be here and like I said, nerd out a little bit about falls and geriatrics because it's definitely going to be a big research agenda of mine over the next couple of years. So looking forward to chatting with all you good folks about 1.5 journal articles tonight.
I'll go next.
Go for it.
Good evening, all. Abby Gordon, sports physical therapist at Seattle Children's Hospital. So pediatrics, and just always like to support the PT crew and learn something new on a Monday night.
Kyle Knopf, physical therapist, Madison, Wisconsin. I work primarily out of the emergency department at one of our local hospitals. I'm an orthopedic certified specialist. Just got my 10-year renewal last month, so don't have to worry about that for a few more years now.
That process. Not looking forward to any of that.
And hey everyone, my name's Stephen Brock. I'm a physical therapist down in Tampa, Florida at the James A. Haley Veterans Hospital, and was tasked to start their emergency physical therapy program there. Orthopedic certified as well.
Awesome.
I guess I'm the nerd. I'm the neuro certified PT in the room and just finished my 9-year re-upness. So, and it sounds like they're delaying the 10-year thing for us by a year because of COVID or something like that. So I don't have to deal with that next year, but soon enough. But I'm glad it was at least a little less of a process this time. I think I'm starting to finally figure it out. I'm glad you guys are here. These articles are really interesting to me. One particularly, the one that uses Medicare data to kind of support the use of physical therapists in the emergency department, particularly because Medicare did take a minute where they decided to stop paying for evaluations in the emergency department. So I think this data shows that it is an effective use of time and resources. So, and I am not a geriatric specialist, so I thought we would have F. Scott talk to us a little bit about what we need to take away from these articles.
Yeah, so I think we can start in the American Journal of Emergency Medicine, right? With the essentially it's a letter to the editor, right? Which I always think is kind of neat because it's just somebody kind of, giving their thoughts on something here. And, if we look here at just the first line or two, right? Previously shown that incorporating physical therapist into interdisciplinary ED team, it improves patient and provider satisfaction. So boom, that's one positive right there. PTs evaluate and treat wide range of diagnoses and are well suited for the ED environment. They've been shown to improve patient-oriented outcomes, reduce length of stay in the inpatient acute care setting. All right, great. So we see some positives here, right? I can honestly say in 2006, I think, when I was in a master's program of physical therapy, the emergency department was not even talked about. It wasn't even a thing. I'm super pumped, A, that it is a thing, but B, you guys are really leading the forefront and taking the ball and running with it because A, you can see the research is there. The data shows that this is a necessary thing to have. And I think realistically, if we look at the big picture, it's something that I'm proud to teach my students about and to introduce them to, because looking at the geriatric side of things, falls is obviously, number one thing when it comes to geriatrics, as far as like injuries and those turning into worse outcomes, right? Broken hips lead to a lot of infections, lead to a lot of deaths, and just negative outcomes in the hospitals. So falls prevention is huge. And if we can do anything to affect that, that's beneficial in my world, in the geriatric world. So if we do a little bit deeper dive here on the letter to the editor, it'll lead us to the article that we're going to talk about. But again, the one that they highlighted here from the article, we're going to talk about the lesser article. Seeing a PT in the ED after a fall can reduce the likelihood of falling again in the near future. So that's the big takeaway, I think, from the letter to the editor. And then we'll look at the article that shows the support behind that, right? And so if we look at this lesser article here, they were trying to figure out if geriatric folks were seen and treated by a physical therapist in the emergency department, did it improve their outcomes in older adults who have had falls, right? Well, overall, they found that yes, it did, especially in the 30 and 60-day range, which is great, because that's when, if they're going to fall again, we think that's really the main area that it's going to happen. So if we can decrease those numbers, that's going to help tremendously. Now, the big thing here, I think, that we kind of have to take away a little bit is, okay, maybe they're not set up yet. Maybe they don't have a physical therapist in the emergency department, right? So that could be the first barrier, right? That's the first potential. And like I said, 2006, which doesn't seem that long ago to me, but is, better part of a decade plus, wasn't even a thing, wasn't even on the radar. I know it's been around for a while. I know it just wasn't something that was taught. And again, a lot of it has to do with what's on the NPTE and what we're having to get through as far as curriculum. So I'm very fortunate in that we have a pretty solid sim lab, and 2 or 3 of the courses that I teach allow me access to that sim lab. And from that sim lab, I can kind of create whatever cases I want. And so if I want to introduce a case like a home health case, we have something upstairs where we can go into a home health setting. Acute care, we have that. Got about an 8-bed sim lab for acute care. And then again, if we kind of wanted to do an emergency room setup, we could do that as well. We have a 2-way mirror room that's got one of the beds and the cameras. We call it the hot seat, where we do a lot of our sim stuff. So we can easily set up an emergency room triage type situation for there. So I get the pleasure of being able to introduce whatever settings I want to, which is great. But I think the first question that we kind of have to ask is, all right, first off, if Medicare, again, I don't know why they stopped paying for evals in the emergency department. That seems ridiculous. But this data is not just like, surface level data here. We're talking 17,000 plus entries here, So it's pretty substantial data. And if we can get that much data supporting, decrease in falls, it seems like a no-brainer to me that, yeah, it works. But, at the end of the day, we have to figure out, if it works, why aren't people being seen by physical therapists in the emergency department? So I think that's kind of the first question. And again, I think realistically, like we kind of talked about, one of the barriers may be that it's not even set up yet, right? It's not even at that point. But what are some of the other barriers that you guys think are happening with regards to not seeing a PT in the emergency department? I'm just curious. And again, you guys are working in the ED, so you would know more than I think, as far as what the issues are with patients not being seen.
I think for me, sometimes the doctors have already triaged ahead of time.
Mhm.
So they've fallen, and there are obviously the cases that we do get consulted for, but a lot of times they've said, this patient's too good. They got up with a nurse to the bathroom. I really don't see a need for you guys. Or the exact opposite. It's like, there's no way they're going to be able to get up and move around. We're just going to admit them.
Gotcha. So if it's bad enough where there's a fracture or some sort of, high level of pain that we just can't affect, they're just going to go ahead and admit them. Whereas if they're too high level, they're just going to kind of send them home. And we'll get to another question about that in a minute. So hang on to that thought. But I mean, overall, if these numbers are right and we're, helping prevent, falls in that 30 and 60-day ratio, then I think we probably need to be doing a little bit better job as physical therapists, kind of advocating for the elderly population, especially post-fall, right? So, I mean, again, my takeaway from this is just the sheer cost on the healthcare system that the geriatric population brings into the mix when they have a fall, right? I mean, it's astounding. I think it said something to the effect of $31 billion that it costs Medicare to help these elderly patients after they've fallen. I mean, that's huge, and so if we can even reduce that by a third, right, that's still, we're talking multiple billions of dollars. And I think realistically with these numbers and what we're seeing here, we can have that kind of effect on people. So I guess my next question then becomes, why do you guys think it's important for us to step up and help these patients that have had falls in the emergency department? Obviously, cost is a big one, right? But what are some other reasons that you think that it may be important for us to really step up and advocate for geriatric patients post-fall?
Stephen, you have a really high volume of older adult fallers, correct?
Yes. It's kind of interesting though, in the I don't get as many as I thought that I would. And it's kind of, I've run into similar issues as to what Kyle is facing now, and I'm still trying to figure out the ideal triage process to see these patients. But a lot of the times, by the time I consult with the doctor, it's more so, oh, yeah, he's independent and this was accidental, or he's getting admitted. So I'm still trying to parse out if I can somehow get to the patient in the triage process before the assigned provider gets to see them. So I'm still trying to figure out a fall algorithm for our particular program that will achieve all these things that we're talking about tonight.
Yeah. Well, and that's kind of how I want to attack this, is like, all right, so again, we're addressing another barrier, right? The timing of when we see them that may affect our ability to have an impact. Anything else?
When I think of barriers, and I mean, we're talking, Rebekah's in Colorado. I think Kyle just said Wisconsin, right? Steven's in Florida, and I'm in Seattle, and I can't order imaging, nor can I order DME as a physical therapist. So I don't know state by state or location by location, like what your facilities allow or what your license scope allows. But I think that's one of the reasons why I have interest in seeing where PTs in the ED push the profession and why these conversations are interesting to me.
Yeah, I get a very VA type feel. Like the VA has a lot of benefits and things they can do. Imaging, they can order some meds, right? They can do a lot more than the average PT can do. And I get that sense in the ED that could be some neat avenues to take,
Well, we took a run at that at the House of Delegates, but alas, we were unsuccessful.
Yeah, it'll get there.
So far.
It's just a matter of when.
Challenge accepted.
Right.
Do you think there could be a process similar to how do they classify the physiotherapists over in the UK? Advanced practice physiotherapists. Do they go through some sort of formal certification process to be able to practice in that setting before they can practice to what we're competent to practice at?
Each country's a little bit different, to answer your question, but they're still bachelor's trained. We're at a higher degree level, but still have managed to work ourselves into less responsibility.
It seemed like the language in the letter article made it sound like they go through special type of training to become a quote, advanced practice physio. But where was it?
I feel like
I don't
an
know.
advanced practice physio still isn't up to the standards of a DPT though either, you know? Like you said, you might be going from a bachelor's to maybe a master's level, but it to me seems like a bachelor's with some certifications or something on top of it, you know?
It's a hot take. I like
Yeah.
it.
Yeah.
All right. Well, the takeaway I wanted to get from all of this, from the two articles, is all right. We know some barriers. We know some of the issues. What can we implement then to start making this more helpful to the geriatric population, to try to get this out there for more people? You know, because I think two of the big things that we can do as physical therapists to help that population is one, some sort of exercise program, right? That's going to help maybe with strengthening for sure, but also maybe some sort of balance stuff as well, some sort of exercise program they can perform safely at home, almost like, you know, a home exercise program that you would send home post home health or something, right? Something where they can kind of hold on to the countertop or, you know, have a chair next to them or whatever it may be. The other one, and this is where I think our biggest impact could be, is the education side of things. You know, I think, like you guys were talking about, if we can educate the patient anywhere along the spectrum, right? If anybody falls, there should be like a standard education implementation, even if it's too far gone and they're fractured, or they're too good and they're going to go home and it was just a misstep or a mistake, right? If we can educate the patient as to a couple of things that they can do to help their overall health and wellness, whether it be strengthening, whether it be, you know, bone density scans and follow-ups, whether it be balance training, whether it be getting into a community program that involves Tai Chi or some sort of movement activity, and here's the resources around you and your community, right? Those bits of education, I think, can fit in anywhere along the spectrum and it can still be beneficial. So even if we're getting our hands on them or we're seeing them or we're giving them a home exercise program, if we can put together some sort of education program, I think that could be helpful as well. What are your guys' thoughts on that?
Well, one thing that I'm interested in is kind of the geriatric emergency department accreditation process. And I think that's one way that PTs can start making things a little bit more appropriate in the emergency department for older adults. Part of it is, one thing I like to say is, like, the emergency department is no place for older adults because of the environment, the limited culture of mobility, the limited amount of assistance that's available, the propensity for patients to be exposed to things that cause delirium, medication delays, food and nutrition access, like so many things that really are not optimal for older adults in the emergency department. So I think looking into the geriatric emergency department accreditation program is one way that we could do some of that. And some of the components of best practice that they are encouraging are geriatric focused education, just like you said, and interdisciplinary staffing, providing standardized approaches to care that address common geriatric issues, ensuring optimal transitions of care from the ED to other settings like inpatient, home, community-based rehab, or long-term care, and promoting geriatric focused quality improvement and enhancements of the physical environment, including having appropriate supplies for those patients. And one example that I can think of is when you have patients who use Depends on the regular and there aren't any available in your emergency department, that puts patients at a high risk of a number of different impairments. So that's one way that I think we could start to standardize that, by not rebuilding the wheel, but really by kind of joining this effort.
Yeah, I like that. And I like too that they mentioned that, you know, in Singapore there, they implemented the STEPS program, right? Which again, I think is a great step toward, pun intended, some form of education, right? Like, here's all you need to know about health and wellness with regards to falls. Here's a home exercise program to work on that, you know? So again, I think if we can get to the patients, no matter where it is along the spectrum, whether it's, you know, it's too easy for them and they're ready to go home right away, or it's too tough and they're, you know, have a fracture or something. So I think that could be a way to kind of introduce, you know, a standardized program. Would just be, you know, talking to the physicians or the decision makers, so to speak, and just say, you know, hey, as physical therapists in the ED, here's our program, here's what we're proposing. Every geriatric patient 65 and above who has a fall, let's at least get them educated on some of the things that may have caused the fall, could prevent the fall, and can just be helpful in general, right? Some general health and wellness tips. I think a lot of that has to do with the relationship too that you have with those folks in the ED. But it sounds like if they, you have the program intact and in place, and they brought you on for a reason. So I think it's just having a place at the table, so to speak, to have those discussions. But I think that to me could be the biggest way to have an impact, And again, I'm partially biased because I'm in academia, and I think that education can solve a lot of things. I feel like whether I'm treating or whether I'm teaching, I'm educating a lot. If I go home and I have a voice at the end of the day, I probably didn't do enough educating. So that's just my 2 cents.
Kyle, are you guys implementing anything?
No, not really that formal. It's really interesting to hear you talk about this, because this is something that I haven't really thought about necessarily. Obviously we're giving home exercise programs, but generally nothing outside of that that's specific. And I feel like that would be super beneficial to what we're doing every day.
Yeah. And I don't want to get too into the weeds here and really into the minutia of things, but it could start with just like the fear avoidance scale or something like that, something that kind of gives us an idea of, how fearful are they of falling? And that's something that I'm probably going to look at in the future, but why are they fearful of falling, right? It tells you a lot of the fear avoidance scale stuff tells you like, yes, they are afraid of falling, but it doesn't go into the depths and the levels as to why, right? Is it because they're afraid of breaking something or injuring themselves? Is it because they're afraid they won't be able to get up? That's a big one, right? Is that they feel like they're going to end up on the floor and get stuck and not be able to get back up, which is why falls recovery has been such a big push lately for us, at least. I'm hoping other programs are doing that as well, but it sounds like they are. Or sometimes it's just, fear of losing independence, fear of the unknown. Like, I don't know, if I fall, it could be over for me. Like, they might just put me in a home, or, just that. And so I think we need to do a little bit deeper dive on that questionnaire about, why they're afraid of falling. So if you can start with some sort of icebreaker type questionnaire, like, hey, you had a fall, we checked you out, things look okay, and we're going to get ready to send you home here. Would you mind just taking a look at this quick questionnaire? It's, about 10 or 15 questions. Go ahead and fill that out. And then, we'll do a quick screen based on some of those answers and see which of this, packet might be helpful to you. And then again, I don't want to burden the primary care physicians or, some of their other docs maybe, but if it is an issue with like, hey, just so you're getting up there in age, bone density is probably kind of decreasing a little bit here and there. Might want to look into starting some supplements if you're not already on them to kind of help with bone strength and bone integrity, because that, again, if you should fall, that could help prevent a fracture in the future, load bearing exercises, right? Like, hey, just because you're getting older in age doesn't mean you're not able to do some of these things, right? We can do hard things, even, at older ages. So, I don't want to underdose you. I want to make sure that we're loading the body appropriately. But, the more lifting you do, the more load you put on the body, the better the bones respond to that. So, just trying to have some of those conversations and outline some big topics and themes that they can follow for just general health and wellness, not only falls recovery and falls stuff, I think that might help open the door to, again, being helpful on the education side of things, so that the physicians or the NPs or PAs or whoever's doing the triage type stuff, they don't have to worry about that. They know we've got it covered, right? If anybody's had a fall, they're going to come through, do the questionnaire, we'll take some information, and we'll try. And again, you can use it just like this study. You can use it for tracking too, to see how you're doing with regards to keeping people from falling and keeping them from returning from another fall within the first 60, 90 days or so, So that's kind of another way to kind of bring it up to the stakeholders to be like, hey, I think we're doing a pretty decent job. You guys are, getting rid of the people that don't need us, admitting the ones that do. However, I think we could help on both ends of that spectrum. And obviously the ones that you do get to see, that's great. You'll help them hands-on wise and really get to craft a program that works for them. But I think it also is important to try to catch those other two ends of the spectrum too, so that everybody gets a touch point when it comes to falls. And I'm not trying to implement more work for you guys or anything like that, but it's just something to consider, because like Rebekah said, it's better if we can keep the older folks out of the emergency department. So one fall sucks, but let's try to keep it at that, not have any more if we can avoid it.
I'm putting another article just in the chat from a physician called Elizabeth Goldberg, who I interviewed on the podcast and did a blog post with her. Her research is she is an emergency physician. She was just at Brown University. Now she actually works at my hospital. We just stole her away, which is great. So her research is really focused on physical therapists in the emergency department for older adult fallers. And her program is called GAP Care, and it stands for Geriatric Acute and Post-Acute Fall Prevention Intervention. And so they actually do have like a standardized process that they follow. And
Beautiful.
Yeah, and it's a pilot program right now. I guess we're going to be helping her complete that research in the spring, trying to pull together the last bit of subject data that she needs. But she's a huge proponent of PT, particularly in the emergency department, because of that. Yeah. And so her study kind of included having pharmacists and physical therapists see the patient so that they could take a look at any medication related falling issues. Yeah. And that's one thing we talk about a lot in our course about evaluating older adults in the emergency department is the impact of polypharmacy. Yep. So they really include that. And one of the things they have in their flow is whether or not so they're seen by they're triaged, they have their vitals taken, then they see a physician for any lab testing, EKGs or imaging they feel is warranted. And then the gap care is actually seeing the physical therapist and the pharmacist. And then they're discharged with appropriate DME as needed.
Yeah, so that I like that.
Yeah. And so then what they're measuring is 30 days, 90 days, and 180 days. And their ED index visit outcome measures that they use are the TUG assessment is one, and easy the Barthel ADL index as well, so that they can kind of measure things. And so then they kind of retest that with those patients over that time. They also make sure with their use of research assistants, which obviously we don't have time for, that these patients made it to their follow-up, whether that was to see a PCP or to see a PT. They actually have somebody that goes through and makes sure, did you get to where you needed to go? And because they have that kind of extra support, they can really call their primary care provider and say, hey, these are the factors that we're noticing in your patient here, so that maybe they can get more appropriate primary care.
Yeah, that was one thing in the one study there, the lesser study. If you look at it, they were saying, I feel like the US only 3% actually went and saw a PT, following their fall. And their visit to the ED, whereas Canada was not much better. It was 4% or something. So I think, like you guys said, there's a lot of that missed opportunity there where it's either they're too good and they're going home right away, or they're too fractured and they're damaged and they're being admitted, but again, that GAP program sounds like it's perfect for all fallers, just blanket across the spectrum. Because at the very least, you're getting 2 more touch points, right? You're getting pharmacy and you're getting PT. And again, even if we're not working with them directly and having them do, exercises and crafting a very individualized PT, home exercise program, just the sheer, basic education could be enough to kind of at least get the wheels turning and at least get them to the people that make a lot of sense, So,
yeah, I think the only thing that I feel really kind of isn't feasible is that they do use a tremendous number of outcome measures, right? Because it's a research study. Yeah. And every outcome measure they have listed here is great. So, they have the timed up and go, they have the AMPAC, they have the TENETI, they have the ADL index, they have 5 times sit to stand, they have the falls efficacy scale, they have a medication questionnaire. they have the 6-item screener for cognitive impairment, which is great if I had time.
Yeah, like a day. I need
do
a day
all
to
of
fill all that out.
Yeah. And like also a lot of my patients, I feel like really wouldn't be able to fill out a lot of that.
Yeah. No, I think, you could probably narrow it down to about 3. I like the FES maybe, again, to kind of get an idea of why they're afraid of falling, or, what might have caused the fall. The tug is a good one. That's short and sweet, and then maybe the AMPAC, because that's 6 quick questions that give activities of daily living. So
yeah,
those 3 and you're good to go. Yeah. I mean, that's an acute care test. That is, what it's made for. Simple enough. I feel like that's probably enough. I don't, now again, if we want to help with the study, you got to try to do all these things. But if you're just saying, hey, look, I like your study, great program, we'd like to implement a short and sweet version of it, can we work with you? Can we do something? Can we take the basis for it and move forward? I think that would be a pretty solid way to implement something that seems to be already working and gaining momentum. So that's my 2 cents. It's my story, and I'm sticking to it. Any questions you guys have? Anything I can answer for you? Anything pressing that you want to know about in the world of Jerry?
I just think that I'm excited because I feel like this is really new. And I do think we talk as PTs too much, maybe not too much, maybe not enough about prevention. And I wonder if as we implement PTs in the ED more, are we going to see this go, previous into more primary care and say, like, you're over 65, you need to go get a physical, and a PT could be in your primary care doc's office and give you an exercise programs for prevention. I mean, obviously that doesn't remove the need for PTs in the ED. I'm not trying to do that. I just feel like, we do such a horrible job taking care of our elderly population in our country. And I feel like it's a little sad.
Yeah, I mean, again, it's not a population I thought I was ever going to work with. I thought I was going to be, an ortho bro and be the New York Mets physical therapist. Like that was my life's goal, and then life kind of got in the way, threw me some curves. I tried a bunch of different things, and I just ended up with, skilled nursing facility and home health. And I just found that I really enjoyed working with geriatric population. Like they're fun, they're witty, they have great stories, they love talking about their life experiences. And I've learned a ton from my patients over the years. And I think you're right. I think we have done a pretty crappy job of treating them just in general. I think if, when we look at prevention, we kind of tend to think younger, like, the 20 to 30 range, so that we can prevent things like high blood pressure, like diabetes, obesity, all the things. And it's like, okay, what about the other end of the spectrum, right? A little bit older in age, the 70 and above age, what can we help prevent there, right? And I think the ED is a really good place to start getting some data and stuff on things that we've implemented that have helped prevent or lowered the occurrence of some of these things. And that's the big problem with prevention, is that you've got to show that what you implemented prevented the thing from happening. So it's hard to get the insurance companies to get behind you when you're like, well, look, it didn't happen. They're like, well, how do we know that was your thing? It's like, because it just works. Like,
and that's what this article does.
Yeah.
Which
So
is awesome.
Yeah. And again, I think you're right. I think the ED is a great opportunity to make some of those preventative changes and show data that it is working. It's going to take a little bit of time. We have to, cultivate the data. I think it's going to take a little bit of trust on the insurance company's part, which who knows how that'll go. But yeah, I mean, the framework is here. The foundation is here. We just need to have those smart people do the research and get it out there for us,
I think too, when you talk about prevention, like, think how many healthcare dollars could have been saved if we really focused on prevention with this whole generation of older adults.
Yeah.
Like, where were we 30 years ago for them, 40
Right.
years ago? Like, we could have made some huge impacts at that point. to help prevent them from having so many comorbidities, like was discussed in the article. Like that's a tremendous number of patients with multiple diagnoses.
Yeah.
And I talked to somebody, I went to a doctor's visit the other day, and she was like, you're the only patient in your 40s that I've seen today that doesn't take any medication. And I was like, wow.
Yeah, it's because
that's not heartening.
No, it's a knee-jerk reaction. We're very reactive with medicine. You know, we're not proactive. And I
was interviewing for my life insurance physical, and they're like, well, we need a list of your medications. I'm like, I really didn't fill it out for a reason, you know. And I think it's just, then I think about like what all the medications like that my mom takes, for example. It's tremendously long list. And so I'm like looking at that generation and thinking, how can I work back from there to help prevent some of that? But I think we kind of failed a little bit with that generation of folks, and hopefully we're doing a better job with the generation behind. But I think even they're getting like almost worse health care at this point.
Yeah, I mean,
prescribe medication instead of prescribing other more easier in some ways but harder in other ways interventions. So I worry that it's going to go in the wrong direction a lot longer before it changes.
I think you're probably right.
Just even in pediatrics, like seeing, I mean, like that's what I have. So I mean, I did work in a SNF when I was a new grad, but like the kids who are like, oh yeah, they're giving me meds, or my family decided to try medical marijuana. I'm like, you are 14. We need to have conversations. Like that's not the same conversation when you're 25.
Yeah.
Yeah.
No, and I think, you know, it's at least the newer generations that I'm seeing come through PT school and move on. They kind of get the health and wellness thing. They're, you know, trying to do the right things. They know that movement is medicine. They know they've got to stay active. They know they've got to eat right. Like, you know, there's a lot of health and wellness type people. And I was just at ELC there up in Milwaukee there, and Joe Tata did a presentation on mental health and mindset, and how PTs can kind of get involved with that as well. And he's big into health and wellness. He just released that integrative wellness book with like 50 of the greatest authors in the PT world. It's an amazing book. I've just started reading it, and it's like a greatest hits, like a who's who of PT. It's pretty well done. And you know, again, Mike Eisenhart and crew, right? They've been beating the drum for years now, saying we need to treat further up the stream in order to prevent these things, because again, it's going to save a ton of money. And that's what I think this article, that's the main takeaway for me, is that look, 31 billion on falls put on Medicare, right? We've got to lower that number, and we can do that. We can have that impact. But I think it's trying to implement some sort of program for all of our fallers, all of our geriatric fallers, whatever it may be. Let's just try something, anything that everybody gets a touch point. And I think, you know, big picture wise, that, and this is totally anecdotal, but I think it'll help lower the reoccurrence of falls. So that's my TED talk. Thanks for coming in.
In the vein of the ED being no place for a geriatric patient, we're talking about education, right? And how to, I guess, most optimally deliver that to a patient. I mean, I think we talked on, you know, earlier journal clubs that, you know, the average amount of information that is retained in an ED visit for just a normal person is like 3% of what's said, or just something astronomically low. So I can only imagine, you know, like you said, the ED is no place for a geriatric patient. A, just just the environment itself, but B, they're probably overwhelmed with what just happened. So how much are they truly going to take away from that visit, and what type of educational modalities, platforms, techniques, you know, learning style assessments can we use in a fast-paced setting to, like we said, truly watch out for these people, right? So I know it's easy to just slap a packet in their discharge packet. You know, no one's, you know, my 75-year-old grandpa's not gonna read a 25-page packet about why he shouldn't fall, right?
Nope.
Or scan a QR code to download the information.
Yeah.
I think that we have to definitely, and again, the good thing is with new generations, they're getting better and better with technology. So eventually they'll be able to handle that stuff. But I think, we give them a one pager, a one sheet, right, with 3 main takeaways. Again, 1 or 2, maybe 3 functional outcome measures, right? Maybe a questionnaire or 2, and then a tug or something like that. Same thing on the back of the one sheet. Maybe you have your 2 or 3 exercises that are going to be most beneficial to balance and falls. And then you have videos available for the same stuff, just reviewing that same stuff. If you go to this link, you can watch the videos on your phone or whatever. Audio version, right? Here's, for visual impaired, maybe you have some a podcast version or whatever, right? An audio version. And then again, I think physical therapists were pretty decent with demonstration as well. There was a good app called Switchback app, and it's something that they use in outpatient a lot, where you can film the patient doing the exercises that you taught them, and then they have a version of it on their phone of them doing the exercise with you giving some cues or whatever it may be, right? So I think that could be a good one if we could kind of set it up with them and show them, just hit this app. Here's your 3 exercises. Watch that. That's all you have to do, I think simplifying the education has to be, because again, I'm teaching 25 to 30-year-olds, heading into a career in PT, and their attention span is like 2 to 5 minutes. It's brutal and it's getting worse. So I get it, adult learning and adult education has to be short, small, digestible portions, But again, I think we can hit like a best of, a greatest hits, top 3 kind of thing with all the things we're trying to accomplish, and just package it into like a nice little one sheet and just be done with it. Because even that, if we have that one sheet and we have it in 3 or 4 different formats, I think even that would lower the occurrences or reoccurrences of a fall. I don't know by how much, but it's got to be some percentage as opposed to doing nothing. Because again, I feel like the geriatric population does get a little bit neglected, and it's like almost like they're expected to fall. Like, well, they're just gonna fall. They're old, they're fallers. So, I think underdosing is a big issue that we have with our geriatrics, over medicating, and then just not care, not that it's not caring, but not giving enough focus to the population, like really knowing the ins and outs of healthy aging, right? Aging is a process. It's going to happen to all of us. So we kind of have to take that in mind when we go to treat our geriatric population, just realizing it's part of the process and we need to know about it.
Yeah, I will say they just, over the very short time that I've been in PT school and been a practicing PT, there's been an increasing competence with, cell phone use and the use of technology. So if there's just some, I know the VA, there's a couple, text-based apps that we use to, disseminate education and automate care. And veterans and they're these geriatric people, they love the latest and greatest technology. So they like being involved in, the latest and greatest app or this or that, or so I mean, we utilize a text-based platform that educates people coming into the ED with low back pain, like acute on chronic, or just an acute flare of back pain, and it kind of guides them through like a 2-week program to just educate them on pain and how to modify their activities and how to really just get back to movement and avoid bed rest. And it kind of gradually, sends them, like you said, bits and pieces of education here and there over a 2-week period that's not overwhelming. And like you said, at the end of the 2 weeks, hopefully they're able to self-manage and hopefully prevent return visit to the ER for a similar issue. So yeah. I'm thinking maybe use a similar platform, like a text-based thing, just sends them a couple texts over a certain time frame. Just here's a little nugget to chew on, and then a couple days later here's another nugget. But then maybe something that we implement in our ED program and then we can just track the outcomes from that.
Yeah, I mean, it seems like an easy sell. It seems like this should make sense to the stakeholders. Like, there's not a lot of downside here. I don't know that it becomes that much more expensive now. When you talk about maybe onboarding a new tech program, maybe, but if we can just start with some sort of easy, simple program, and then diversify the way we disperse it, then I think, we're onto something.
Funding won't be an issue thanks to all your tax dollars. So
yeah. I'm actually possibly working on a study through the VA with Mariana Winggood, who does a ton of research in the VA, and so she's also a geriatric specialist. So she's been showing me the ropes and the funding and all the fun things that they get to do with taxpayer dollars. So, I think it's well warranted, though, too. I think, for your services and everything that these patients have provided for the country, I think it's fair that we can at least give them, quality care and try to find best practices for them. So.
Anybody have any final questions or thoughts?
So if you have your neuro certification, Rebekah, and F. Scott's going to go for geriatrics, and Kyle and Steven are ortho, what do you think is the best path for the upcoming people who aspire to be ED PTs? Or do you think like acute care's specialty needs to expand to acute and emergency? Or like, do you have a thought of where this needs to go?
No, well, I think ideal state maybe would be that there is like a board certification in this area, but I think that's like a very long way away. And I think the best thing is to become an expert at being a generalist at the top of your scope. So I would actually like not encourage people who want to be in the emergency department to get their OCS or to get their NCS. I would just encourage them to spend that time being well-rounded. Yeah. And a student asked me this week, because I was talking to the students at Northeastern University. They said, well, like, if we want to do that, how should we prepare? And I said, well, any clinical setting you're going to go to will give you lots of information. So what I would suggest is a variety of them, and not like just ortho or just acute care or just neuro. Like, you need all of the things.
Yeah.
In order to be successful. And we talked about that we're not inpatient therapists, we're not outpatient therapists, that we really should be all patient therapists. And we should be able to really focus on being top of our scope, no matter what setting that we're in. And there was more of a learning mindset as opposed to a learning location.
Sure. Makes sense.
So my hope is that we can one day develop that, but I think we need a greater body of people to contribute to that work. And we need some validated competencies. And I've talked to some people about starting that process, but that's a really rigorous process. So I think before you can have like a board certification, you really need to have basic competencies first.
Yeah. I mean, just looking at how pain is trying to become their own academy and board certification, which I think is much needed. And I have strong opinions about pain, like living under orthopedics. But that was really the second piece of my question was, how do you start like an ED special interest group, knowing that you don't want it to necessarily live in neuro or live in geriatrics or live in ortho?
Yeah, it's a thing. And Kyle and I are on the emergency PT steering committee. So we're definitely trying to move that in the right direction. Because right now it's a kind of it's not even a special interest group. It's a focus group, which is housed under the Academy of Acute Care, which I think makes sense if you're looking at it from a very limited perspective, because emergency physical therapist practice does not just include the ED. That's my specialty. So that's mostly what I talk about. But if you're only considering the setting of the emergency department, acute care kind of makes sense, because acute care generally like implies hospital setting. However, I think if we again focus on not being inpatient therapists or outpatient therapists, and we think acute care means acute, it is kind of in the right place.
Yeah. Well,
but people don't look at it that way.
I don't think of it as I think of emergency PT as disaster relief.
Yes, which also falls under emergency PT. And so we don't want it in its own silo, but is an academy the right answer, or is it a council? Is like, I don't know what the correct answer is. And it may end
a
up being
networking
like
group.
emergency PT with a special interest group in wilderness, or a special interest group in disaster relief, a special interest group in sideline care, a special
Sure.
interest group in combat, and a special interest group for the emergency department. But that takes so much like
Yeah.
work and collaboration. And I'm interested to see how the APTA is going to manage kind of the restructuring that they're doing over the next couple of years with the different opportunities for people to engage across academies. But also I just wish we would silo ourselves a little bit less.
I know, that's why we did that motion this year, and I don't think it ended the way it was intended.
Yeah.
So it's really interesting to hear these conversations, because it was driven because of pain, but it applies in balance and falls being a SIG in 3 different academies
Well, and
for
is
right
pain an
reason.
orthopedic issue?
No.
No, it feels neurologic to me. It feels psychosocial to me. It feels acute. It feels like, I think it could be in so many different places. So
Yeah.
I think we'll see how that goes. But in the meantime, we're just going to keep pushing and trying to like get the message out there, so at least people have specific resources they can rely on in a group of like-minded people. So with that, I think we'll wrap it up after that long soapbox of mine. I have a few announcements. If you are interested in learning more about how to make the emergency department a little bit more effective for older adults, I do have a part 1 emergency department geriatric evaluation examination considerations for the older adult that is available. And then I wanted to announce the 4th annual emergency PT conference and meeting. This was supposed to be this past weekend in South Carolina, but it's pivoted to a virtual event, and it will be on December 2nd and 3rd. I'll be presenting at that event, and I think there are going to be so many other great people and some wilderness content, as far as I know. I'm not in charge of that, so I'm not sure what all of the topics will be, but there will also be some networking and like a virtual social event. So you can find that online at emergencypt.com. And then we are also going to be putting on a 2-day full-length course for how to start or improve your emergency PT practice in Madison, Wisconsin in January. So if you know anybody who's interested in that, you can also find the details of that on our continuing education page on our website. Our next journal club will be in the first quarter of next year. It's yet to be scheduled. If you have any topics you're particularly interested in, if you could let me know, that would be great. And in the meantime, we've started a kind of a new feature where on the first week of every month, we're doing something called Take 5 for EBP. And basically it's a too long didn't read version of like a cat review of an evidence-based article, so that we kind of have somebody analyze that article for you, drop the top 5 most important things, and then like a full blog post if you really want to learn more about it, still like stopping before having to read the entire article yourself, just so that you can stay evidence-based. You can familiarize yourself with the literature on the topic in 5 minutes or less, because I know we're all busy, and that seems like a quick way to get you a little bit more information. Anything else? Any questions? Anything I'm missing?
It would be cool to have that little summary in a audio version as well. Just
It's
FYI.
on video now. So I have
Beautiful.
There is a like short video where Dr. Jacobson, who is doing that, actually just kind of drops those 5 things in a minute or less. And
Awesome.
You can find that on our YouTube channel. It's also on Instagram and TikTok. I'm learning about that.
Nice.
Yeah, that's a whole different animal. So keep an eye out for that the first week of the month, but you can find it. There's a whole playlist on Take 5 for EBP on our website or on our YouTube channel.
Beautiful.
All right, guys, I appreciate you. And the recording of this will be posted soon. If there's anybody you know who wanted to be here but couldn't, or you want to go back for whatever reason, you can also use this for your any of your continued competency requirements. You can show that your presence was here if you need to do that. Thank you guys so much, and have a wonderful night.
Thank you.
Thanks, guys. Pleasure.